guys the session, but basically what's going to happen is you're going to give your 3-4 minute pitch, and then there's going to be some time for feedback. We're going to do at least 2 rounds, if not 3, depending on how much time we have. So we have a few chances to run through that. Yeah, and then as Amit and Ann just mentioned, make sure all our veterans are at the ED offices next week for our mind reassessment. And then to announce our e-bike liaisons for Dr. Matonis.
It's fun.
Wow. We're really excited to see where you guys take this study. You guys have a lot of amazing ideas already. So,
right, now to go over our winter quarter average numbers for the newbies. So every shift we do keep a track of how many points you get from the number of studies you enroll in. So we do at the end of the quarter average these out to see like who's like doing like stellar. And so we want to shout out those people who are doing really great, and we'll announce that after this slide. So for the veterans, you all should have received a number, a randomized number, so you can take a look and see what your average was for this quarter. So if you want to take pictures or anything, go ahead. Or just like find your number.
Our average points per shift actually went up from last quarter, so really good job, or from all quarters. Really good job, guys. Thank you guys for always being proactive in the evening and getting this.
Let's get excited to see our winners. You can see there's a standout already. There's a little peak on there. And okay, I can go ahead.
So
in
for
third place, go ahead. You wanna just wait? Do I say?
I think flag us.
Okay, reveal.
Flag.
What was your favorite study to enroll during this time?
That's a good question. I feel like they all kind of mixed together, to be honest. But I will say, okay, I don't think this was like during this time, but like when
Yeah.
I was just gonna say, like, it wasn't too involved. She was just like an unhoused patient, but like hearing her experiences like really like shaped my like view of the world, I guess. It was really fun.
Good job.
And then in first place, you'll probably be able to guess it. Mr. Tyler.
Mr. Tyler.
Keep on keeping on.
Nonetheless, really good job to everyone. We are extremely impressed by the continuous effort, continuous motivation. So thank you guys so much. This program would not be possible without the work you guys do. So.
And as our little thank you, we are going to give those 3 individuals priority shifting on the calendar coming out soon.
It's a small jacket for those veterans that know. The small jacket is still in raffle, so keep it rolling. Besides that, we're so excited to introduce Dr. Alyssa Ray from the School of Medicine. She will be presenting today on CPR and codes.
I'm gonna take a few minutes to get set up.
Oh, okay. But that's not good, actually.
Yeah, I just gotta like plug on the laptop.
Oh, okay, wait, yeah, no worries.
Yeah. Do what you gotta do.
Oh, okay, cool. Yeah.
Can we talk about the surgery that we shadowed last week?
Oh, dude.
Oh, yeah, please go ahead.
You want to? I can talk about it. So like 7 something p.m. Luke and I are shifting. Critical coming in. We got ready for a carotid. And at the head of the table, all of that was chaos. It was train versus auto. So
Oh, you got that one.
yeah, we got that one. And came in. The doctor saw some images. We were all expecting the worst, and we got the worst. And the patient, when he showed up, he was as stable as he can be. And then they sent the patient to CT. During CT, the patient lost their pulse. They took him out. They started performing CPR. Luckily, the patient had ROS to send him back to CT. As they were in CT, we asked the trauma surgeon if we could shadow. And by that point, Emma showed up. So all 3 of us went into trauma surgery. We got the scrubs and everything, and we went in. And They already opened up the chest in the ED. So they first of all looked in the chest cavity. They did not find any occurring bleeding in the chest cavity. And then they opened up their stomach, the patient's stomach. There was continuous bleeding. They were not able to locate the bleeding, as they decided to pack the wound and close up the patient to minimize, to make sure the patient doesn't get too cold. And I think Dr. Ray could probably add more clinical notes if there are any questions. But they decided to close up the patient, and right as they closed up the patient lost their pulse. And no one was really sure what was going on. The pulse throughout the whole time was very unstable. Throughout the whole time, there was a very low CP. When I say very low, the systolic was under 80 consistently. The diastolic was under 40 consistently. And then, unfortunately, the patient did not make it, as they announced time of death around 10:22 p.m. And the patient had a pulse electric activity, and I don't know if we'll talk about it in the ACLS class. Yeah, so Dr. Ray will explain that into more details. But yeah, so if you have any questions regarding how to scrub in, how to approach doctors, all of that, I think any MRAPper will be able to answer that.
John, there's like a little how did you do it?
And so yeah, So Dr. Jang was the attending. If anyone saw him in the ED, he usually has glasses and he has a navy lanyard. So I think he's a veteran, not sure. But he was the attending, and then he had 3 residents. 2 of them were trauma surgery, and 1 was plastic surgery, if I remember correctly. And we started by asking the resident. The resident said yes, of course. And we're asked if we know how to scrub in. Luckily, I scrubbed in the past was Miko. Shout out Miko. And then we kind of went up and we did everything. But then, and then we asked the attending. We asked Dr. Jeng actually right after the CT, because in the end, the attending holds the shot, not the resident. So it's really important to double check with the attending and what you can and cannot do. And we went up, you go and you check in with the OR desk. You tell them that you're a student, that you're going to shadow this specific doctor, and then sometimes will know the OR ahead of time, sometimes you won't. And so we just told them, we got our cards, we got our scrubs, and then from the locker room we went straight in, and then we saw the surgery. That's all.
All right. Can you guys hear me okay? Okay, cool, perfect. And then I should probably
unmute. I'm unmuted. And it doesn't sound like we have any terrible feedback. So I think that's good. Okay, cool. So I'm Elisa Ray. I'm one of the ER attendings. I'm one of the School of Medicine's faculty as well. I run our longitudinal doctoring course over 4 years for the medical students. I actually just finished tomorrow we'll finish it technically, 24 hours of teaching about codes in the last 2 weeks to our 4th year medical students. So this was excellent timing because it's super fresh on my mind. Granted, being an ER doctor, it's kind of always fresh on the mind. But we are going to talk today about what happens when there's a code. I'm going to focus a little bit more on medical codes, but I'll throw in some trauma stuff because you guys will be seeing some trauma codes as well. For the most part, everybody's always really, really nice. But there's a lot going on. So sometimes it's really hard to know exactly what's happening, where you should stand, when you can ask questions and that sort of thing. So I'm going to go over some of that in addition to in general, what's going on in the room. Feel free to stop me to ask questions. I brought some props. I brought 2 mannequins that you guys can try CPR on, that you can practice doing intubating and putting breathing tubes in. I brought some of the code drugs so you can kind of see what those look like and that sort of stuff as well. This is not meant to me just be me talking at you. So if you have questions, don't hesitate. I'm generally pretty nice. Okay, so we're going to talk about ACLS a little bit. And we're going to stay a little bit more on this dead side. And you guys are going to hear me use the term dead. And I realize that sounds really, really callous, but that is the reality of the situation. Okay. So if we are doing CPR on somebody, that means that their heart has stopped and that they are dead, and we are trying to bring them back to life. Okay. And I use that because I think it's important that we stay rooted kind of in like the reality of the situation. And we don't think that they are, you know, like dying, like trying to die. Like once we start CPR, they are actively dead. Okay. So that's sort of the side of things we're going to stay on, and all the chaos that happens in the room during that. That being said, when the people aren't dead yet and we're on the other side, there's still a lot of chaos that can go on while we're trying to prevent them from dying on us. And that is something we can talk about like in the future if you guys are super interested, and I can talk about the things that we think about as we go through it. Who here has been around someone that is dead and getting CPR? Okay. Who here is brand new to MRAP? I'm so sorry. This is our first introduction, but also I think this is kind of a nice thing to like get a little bit of information about, because the first time you do see a code, it can be a little traumatizing. And it can be a little jarring in terms of everything that's going on. And also on top of that, there's like so much chaos that sometimes I think for learners, like you look around the room and you're like, I want to see as much as possible and I want to learn as much as possible, but I have no idea where to stand and I don't want to get in the way. And all of that can be like a little bit overwhelming. So hopefully that helps with that a little bit. Okay. So this is the ACLS algorithm for patients who do not have a pulse. And if you do not have a pulse, you're dead. Okay. And so this is generally what we go through and what we think about when someone's heart stops and how we handle the situation. So this is a lot. All right. Especially if you're not used to looking at cardiac rhythms and you're not used to thinking about things like VFib and pulseless VTAC. And I'm going to get into what those are. And I'm going to probably dance for you guys a little bit to help like you figure out what I'm talking about. But this can be a whole lot. So let's break it down a little bit into what exactly we're doing when this is happening and why we're doing it. So what you'll hear overhead is critical ALS in 10 minutes. Or you might hear critical trauma in 10 minutes or 5 minutes or on the ramp or coming in from triage sometime. And that's going to be the first thing you're going to hear. You will probably go take a look at the room to see what's happening. I wasn't in the ER in the last couple of days, so I didn't get a picture of our board, but we have this little glass board that sits right outside bed F that tells you everything that's coming in and everything that's going on. Veterans here, you already know what I'm talking about. Newbies, someone will show you. And that's where you can go get a little bit information and figure out what exactly is coming in, how sick they are, and how starting is. But then you'll probably head over to the room and start to take a look and see what's going on. The first thing I want to talk about is high performance teams. So emergency departments deal with this stuff all the time. This is our bread and butter. We deal with patients that are actively trying to die on us, and we deal with people that are dead and we're trying to bring back to life. And a high performance team is a team that does something frequently. You train for it, you correct your mistakes, and you work really well together. And I think our emergency department does a really good job at having a high performance team and sick patients. The first couple times you watch a code, for those of you that are veterans, the first couple times you watched a code, did you look at it and think this is absolute chaos? I have no idea what's happening. Yeah. And after like your fourth or fifth code, did you start to look around and be like, oh, I can kind of identify who's doing what and like how this dance is occurring. When you do it really well, it's like a very well rehearsed waltz or tango, and everybody sort of has their spot and knows where they're going. So who shows up for this code? Well, the first person is usually going to be the team leader. All right. That is usually going to be one of the resident physicians and one of the attending physicians. So someone like myself, someone like Dr. BC, Dr. Lotfor will be the people that will be showing up as the attending physician, and then one of the resident physicians as well. As the attending physician, it's kind of our job to be backup for the resident and help them out. They're learning. So we want to try and shove them into the hot seat and make them, actually actively participate and make decisions. But we also want to be there to catch them if they don't know what to do or they start to, not trust themselves completely or whatnot. So the team leader is going to be actively running the resuscitation, going to be telling a lot of other people what to do. Sometimes we sound really, really bossy. Because I will literally just shout out things to the void. And everybody knows their role. And so they sort of know when to jump in to do it. But I'm probably going to look a little rude in those situations because I will just be staring off into the room and I'll be like, 1 milligram of epi now, please. Somebody get me some epi. And it's just like the way the dance sort of works. Realistically, I should be making good eye contact and I should be using closed loop communication. So when I say it, that person then repeats it back to me. That way we're all on the same page with things. But working in our ER, I know everybody really well. They know me pretty well. We kind of all just sort of do our part of the dance. The other two people you'll notice will be the timer and the recorder and someone who gives the medications. So the timer and recorder is usually going to be one of our awesome nurses standing behind the desk at the back of the trauma bay. They'll be sitting at the little stand-up desk with the computer on it. They'll usually be inputting exactly what's going on. They'll be watching the clock up on the back of the wall to tell us exactly when it's been 2 minutes, when it's been 3 minutes. And they'll be keeping an eye on all of that. They'll be taking very detailed notes as well at exactly what time things happen, what we do for those things, and how we proceeded forward. The person who's giving the medications may be one of our really awesome pharmacists, or it may be another one of our awesome nurses. It just sort of depends on who's there that day. During daytime hours, we almost always have ED pharmacy, which is like the best thing ever. They are so amazing. But at like 3 a.m., they go home and then we're all by our lonesome. The docs, the nurses, the techs. And so it may be the nurses then are giving the medications. And then past that, you have this nice little triangle here where you have your compressor, you have your person who's watching the AED or the monitor, and you have your person that's managing the airway. So we'll get a respiratory therapist that comes. They are specialists in airway and breathing. Oftentimes they'll be the ones that are bagging the patients. They use a special mask over the face and then a balloon and they squeeze it to help bring air into the patient's lungs. It may also be the resident physician who gets up there to put a breathing tube into the patient to intubate them. We'll usually have somebody who's standing at the AED or the monitor. Oftentimes that's one of our techs. And they'll be prepped and ready to go to pull up the monitor, to push any buttons, to charge, to defibrillate, anything like that that we might need. And if these all sound like fancy words, don't worry, I'm going to break them down in a little bit, I promise. And then you have the compressor, and this is the person who's getting a workout and doing 2 full minutes of CPR. Has anyone ever done CPR? Was it exhausting?
Like just automatic.
Okay, gotcha. Yeah. You guys, it's so exhausting. We do CPR in rounds of 2 minutes. And who here right now is thinking like, oh, 2 minutes is no big deal. I always think 2 minutes is no big deal. And then around 1 minute 30, our techs will be like, Dr. Ray, you want to get off the chest? And I'll be like, no, I'm good. And they're like, your CPR is terrible. Get off the chest. And I'm like, I know, I'm tired. It's really exhausting to push that hard and that fast for a full 2 minutes. It is a cardio workout. And so we switch people out every 2 minutes because everybody's going to need a break, and need a moment to rest. Now, if these are the only people you have, and we're really lucky, we usually have a lot more people than this. We have multiple techs that show up. We have extra nurses that show up. There's usually an extra resident or two. But if these are the only 2 people you have, oftentimes your compressor and your AED person will just switch every 2 minutes. So 2 minutes on, 2 minutes off, 2 minutes on, 2 minutes off. Yes. Yeah. The Lucas device. Oh, when they come in with EMS and EMS tells me they can hang out for a while. We don't have one. I wish we did because they're amazing. So a lot of our EMS crews in Orange County will have a Lucas device. It's this big machine that sits on top of the chest. It looks like a giant arc that goes over the chest. And then there's like a toilet plunger that sits right on the center of the chest. And then there's a board that goes underneath the back and they strap together. And then basically you set the machine and it goes 100 beats a minute. And that toilet plunger basically like pushes on the chest at a rate of 100. It allows for full recoil. There's no human being involved. So it's like much more precise than we are. And it doesn't get tired except for when its battery dies. So our EMS will bring people in on those. And usually one of the first things I do is like lean over and I'm like, are you guys super busy? And they're like, no, it's cool. We can stay. And I'm like, thanks. Because then none of my techs are going to get exhausted. And we have a little bit more time. We don't have one. So when the EMS crew is like, yeah, we're super busy. I'm like, okay, you can take it off and go. Thank you. And they'll take it off and head out. And then we move to manual compressions. Yeah.
Is there a reason why
Dude, I don't know. I'm sure there's a reason. I mean, we have people we need to work out. I don't know. I'm guessing they're probably like super expensive. Maybe they have them up in the ICU. I really don't know though. Yeah. But I would love one. So nice. What I like to do, and if any of you guys have ever watched me run a code or are there when I run a code, I'm pretty specific about where I want everyone standing, what I want everyone doing. And the reason for that is I think it just keeps things a little bit cleaner, a little bit more smooth. So I really like to have one person palpating the femoral pulse during CPR. When you're actually doing CPR, you're feeling blood backflow from the heart, not forward flow from the heart. So you're technically feeling like a venous pulse versus like an arterial pulse, which would be the heart pushing blood forward. But I like to have one person palpating the femoral. That person is the person who's getting a break and they're next up for CPR. And then the person who's doing CPR, when we stop at our 2-minute mark, they're going to step up to the head of the bed and palpate the carotid. And that gives me 2 people palpating the pulse, which makes me feel a lot better when we have a pulse back. Because if I try to palpate it, I'm going to feel my own pulse and I might not actually feel the patient's because they might not have a pulse. So 2 people, 2 brains, 2 fingers, better than 1, gives you a little bit more information about what's going on. And then also everybody just like steps up the line and moves up. So that person that's palpating the femoral will step up to do CPR. The person doing CPR will step up to the carotid to palpate it. And then when we decide we need to do CPR again, because we still don't have a pulse, their heart still isn't working, they'll all bump forward. All right. And then the next person will get in line and be palpating the femoral, ready to go. So one of the things that makes a really big difference here is making sure that people get like some rest in between and making sure that somebody's giving the people who are doing CPR some feedback on how their CPR is going.
We'll talk about CPR here in a little bit.
But oftentimes just having a couple extra people means that you get higher quality and you have better results with your codes. And then on top of that, we have like an ultrasound machine hanging out in the room. And there's usually somebody that's trying to get in there and ultrasound the carotid or ultrasound the heart as well. And it kind of just becomes part of that dance and sort of slipping into any available spot that you can to sneak in. The next image is a little graphic. I'm just going to let you guys know, okay? I work in an ER. Things sometimes are graphic. This is a picture of one of our trauma bays after a critical trauma had gone up to the OR. And so you see a whole bunch of trash everywhere. But the reason why I put this one up is just because this is an actual picture of one of our trauma bays, so that you guys can sort of see where everything is. There's a couple of things I'll point out. Is my mouse actually showing? Fabulous. Okay, so this is the crash cart. All right. This desk over here is where the nurse is usually sitting that's doing all of the recording. The airway, the head of the bed is up here and the feet are kind of down here. So the person would be like laying like this in the room. Okay. For those of you that are veterans, this is like old news, you know our room. This is one of the ultrasound machines up on the boom up here. This is the clock on the wall that we're usually looking at. I took this at 3 a.m. in the morning. This is the patient's monitor right here. And so all of this dance is happening right in this center spot. That really realistically that bed is taking up this much space. So quite a bit of space, and we're all sort of working around each other within that area. We lay things out a little bit different. We just sort of flip where the compressor is and where your monitor is from what that picture from the AHA that I was using. And this is sort of where everybody stands in our room based on this picture right here. So those are kind of our high performance teams. They lead to better timing, they lead to better quality, they lead to better coordination and better administration of like medications and things like that. So questions so far? Okay, cool. Yes.
So like how many people do you usually have like taking pulses and rotating compression?
I like to have 2 people checking pulses. So the person that's getting ready to step up for CPR and the person that's stepping down from CPR when we do our pulse check. And if possible, I like to have 3 people that are rotating out doing CPR. That way everybody gets an additional 2-minute break. So they get like a 4-minute break and 2 minutes on. And then if it's a patient that I think we're going to be coding for a while, so they're very young, or we know the reason why, and it's something we think we can reverse and bring them back to life, I will usually jump in and do a couple rounds as well. That way everybody gets like 1 more set of 2-minute breaks, because it's tiring. Like even doing 2 minutes on and 4 minutes off is not quite enough time to give yourself good recovery to be ready to go again. And so it's really tiring. That's my personal preference. We don't always have that many people. If we don't have that many people, then I make the residents get in and do CPR too. Because realistically, they should be able to run a code and they should be able to help with CPR at the same time. And I make sure I jump in, and if, you know, some poor lonely soul is walking by, I'm like, have you done CPR? If any of our medical students are there, I make them get in line. Because the more time off, the better people will be, and the better the CPR will be. Yeah.
And so one of the reasons I mentioned is because of our carotid pulse check.
Yeah, exactly.
And so how do we come into play with high performance team?
Yes.
And then what can we do to support the high performance team and not interfere?
Oh my God. No, I did not prep anything for that because I anticipated someone was going to ask the question. It's part of the reason why I started with the high performance team. So thank you. And part of the reason why I had the ultrasound machine up here ready to go. So I think the part where you can start is this right here. So the second they call the critical ALS run, you should go take a look at the board and see what's going on. If it is a full arrest, then you should go stand outside that room. And the second you see the resident or attending physician walk in, or you see one of the nurses, you should greet them, and you should let them know about the study. Okay. You guys are not doing it on traumas, correct? It's only for, you are. Fabulous.
It depends on the trauma. So
Yeah.
to have any injury there around
Then no. Yeah. Mhm.
but anything else pretty much it's fair play.
Yeah.
That's the visit that technique says.
Perfect. Yes, exactly. So this critical trauma, this critical ALS run in 10 minutes, that is your cue to walk and look at the board. If it looks like they don't have a pulse, so it says full arrest or TFA, traumatic full arrest, then that's when you want to go introduce yourself. Other question, and then I'm going to continue on the same line.
I'm just gonna check, are all of our newbies familiar with the carotid pulse check study? Just like a show of hands from our newbies. Like everyone's kind of understands.
Yeah. So when they're doing the pulse checks, the healthcare team is doing manual palpation, and then we use our point of care ultrasound or butterfly, and we try to find the carotid pulse, and then we compare the results. So you can actually like visualize it kind of beating on the screen if it's there, and if it's not there, then it's just
Awesome. Perfect.
It's exactly why we wanted to have Dr. Gray come and talk to us. So that you guys, once you are there, it's a really scary situation.
But just having a little bit more comfortability, a little bit more familiarity, especially with the technical stuff.
We can continue on.
It's really important. to us.
Yeah. So you hear this. Go check the board. You see the words full arrest. You see the words TFA, traumatic full arrest. That's going to be your cue to go stand outside the room. And as the nurse walks in, as the resident or attending walks in, introduce yourself. Say, hi, I'm here to help with the carotid pulse checks. I have my butterfly. I'm with the MRAP team. I am planning to stand at the head of the bed and check the carotid pulse on the pulse checks. I personally would go with that method rather than asking for permission and trying to explain exactly what's going on. Most of us know about the study. And I think you're probably more likely to get, yeah, okay, go stand up there than you are if you're like, hey, I'd really like to, would it be possible if I can, we have this study going on, then you're probably going to get attendings and residents that are going to be like, no, not right now, this patient is super sick. And you're like, yeah, that's the point. I'm trying to be here for that. So I would go with that second, like the first option rather than the second option. So it would be like, hey, I'm Elisa. I'm with the MRAP team. We're doing the carotid pulse check study on full arrest. I'm going to go stand up on the patient's right side to check the carotid pulse with my butterfly ultrasound. I'll let you know what I see at the pulse checks.
And you guys should say Dr. Fox study.
There you go.
And Dr. Fox is the chair of the emergency department. So
There's a weight behind it.
yeah,
Exactly.
they're all
Yeah. And if you have like that little bit of confidence and you have that little bit of like, this is what I'm here to do, you're gonna get a lot more people being like, okay, yeah, sounds good, go stand up there. Than you are if you're like, may I please, is it possible if I, because then you're gonna get a lot of us that are like, this patient is really sick, I don't want extra people in the room, please just step out, and then you're not gonna be able to get your nurses, okay? Or to participate, because you'll get a much better view if you're at the head of the bed with everybody. Okay.
Sorry.
This is, I like this.
Tell the attendee what we've seen on.
Oh, okay, sounds good. Perfect. Cool. Never mind. Yeah, exactly. Sounds good. The one thing I do want to say, if you are checking the carotid pulse, don't push down so hard that you collapse it, especially if someone's checking on the other side, because we like to perfuse the brain. But I'm sure you guys go over that when you train the study. Yeah. Cool. Yeah, I doubt you're pushing hard enough to really truly occlude the carotid. But I don't let people check both at the same time, because if we go like this and we have a good pulse and we collapse both of them, we're all going to pass out, because we're not going to perfuse our brain with blood flow, and we like blood to go to our brain. But yeah, I would just be like, I'm here to do this study. We're doing it on all full arrest patients, and I would just like get in there. If you have an attending that is super rude and like, absolutely not, we are not doing this right now, then like, fine, whatever, that's on them. But we're a teaching hospital. We're here for these sorts of things. So I personally think it's totally okay to be like, I'm here to do this. Don't be rude, but like, I'm here to do this. I'm going to go stand up there and check the pulses with the ultrasound machine during the pulse checks. Okay. Now, where do you stand? Okay. So we've got our high performance team. We've got our chaos right here. Okay. We have got our patient laying like this, right? Can you imagine that? Does that work? Okay, cool. Perfect. Awesome. This is where I would stand, right next to the main ultrasound machine. And my reasoning for that is because we're all going to associate it with the ultrasound machine. Okay, so that's part of it. The other reason is this head of the bed spot tends to have a little bit more room. All right. So I need some volunteers. Can somebody be my airway person? That is fun. Perfect. Awesome. Airway person right here. Fabulous person who's doing ultrasound right here for the carotid right there. All right. Then we've got a nurse right here. Perfect. We've got someone doing CPR right here. We've probably got another person right there. And we've got somebody standing at the foot of the bed that's me going like this while I stare at everybody. Okay. So this is kind of how crowded it gets up in here. So you're going to have to be comfortable being a little close to people. And this spot right here is usually far enough away from me, like wrapping the arm and somebody doing an IV on the patient. Okay. And you're up close to the carotid so you can actually check, but you're not in the airway person's way and you're not in the CPR person's way. Does that make sense? Cool. Thank you, friends. You're awesome. So that's where I would recommend standing. There's a good chance when they do want to do an actual like cardiac ultrasound, they might like hip check you out of the way. And when they hip check you out of the way, you're probably going to step up into like the head of the bed position, because the resident will be stepping out of the head of bed position into where you previously were standing, so that they can look at the heart with the ultrasound machine. Okay. But that's where I would stand. I think that's going to be the best place for you guys to get in there, be able to actually do an ultrasound of the carotid, and not be totally in the way. Now, one thing I tell all of my residents in the emergency department is that we're a very tight-knit team and we're a very close team. And there will be times where you may like hip bump someone else by accident, or your arms may touch and that sort of thing. I just don't want anybody to ever be like surprised when we're all standing very close together and there are a million things happening and someone accidentally elbows you or something like that. It's not mean. It just sometimes happens. And you may get people who like either like gently put a palm on your back and ask you to step away, or gently touch your shoulder and ask you to step away, just as an FYI as well. But if anything ever makes you uncomfortable, let us know right away. Okay. But I let people know, because like the attending physicians and the nurses, like I hug all of them. I know them all really, really well. And there are occasions where I will like physically grab them by their shoulders and be like, I'm so sorry, and move them out of the way. And they will do the exact same thing to me, but we have given each other permission for that. Okay. Just so you guys know. So that's where I would stand. All right. Patient arrives. Other questions actually before we bump on. Cool. Patient arrives. Okay. So in the emergency department, we usually get the call ahead of time that someone's coming in without a pulse, or we're watching someone get progressively sicker and we're anticipating it. But if you're up on the floor in your progression in medicine, you may hear somebody yell like code blue. That's the term for somebody who's lost a pulse and they are dead and we're trying to bring them back to life. And then the team will start arriving and all of those people will kind of descend. In the emergency department, we're usually already there. We already know it's coming. There are a few things we do when these patients arrive. We check for a pulse, all right? Usually we have 2 people checking. We check both FEMs, we check one carotid, we kind of all stare at each other and we're like, do you feel pulse? I don't feel pulse. Do you feel pulse? Maybe, nope, I don't feel a pulse. And then we'll start CPR, okay? At that same time, we're also assessing their airway to make sure there's nothing blocking their mouth and that the air can actually get in. We're watching their breathing to see if their chest actually rises. You guys may see when patients roll in, we immediately and they're not responding, we'll immediately pull all of their clothes off so that we can get good exposure and we can look at everything that's going on with them. And we have a good view of their chest to see how they're breathing. One of our nurses will start getting an IV in. Usually they start with the right upper extremity. Sometimes they'll start with the left upper extremity. This just has to do with where we all stand in our little dance. Our techs will get the patient up on the monitor and get them up on the screen so that we can see all of their vital signs, their heart rate, their blood pressure, their oxygen saturations, what the rhythm of their heart is, that sort of stuff. Now, if their heart's not beating and they're dead, they don't have a blood pressure, just FYI, okay? Because nothing's pushing it forward. We've turned the garden hose off. And then we'll get pads on their chest, okay? And then someone will be trying to get a little bit of the story and find out what's going on with the patient and why this happened. So CPR. CPR is pretty much the most important thing you can do. There have been numerous studies over the years that have shown that time to bystander CPR is one of the biggest indicators of survival. So in the fully colored in black bars, you have patients who got bystander CPR from minutes to collapse to arrival of paramedics. And in the stripy ones, you have people who did not or got delayed CPR. And the patients who had immediate bystander CPR had the best survival rates. So you can see the 0 to 4 minutes that had immediate bystander CPR had 73% survival on this study that was done in the 70s before any of you were born, before I was born. And then of course, the longer it takes you to start CPR, the lower the chances of survival you have. Okay. So high quality CPR is one of the most important things you can do for patients whose heart stops. And if you guys ever have the chance to take a BLS course or a CPR course, I highly recommend it. If you are ever in the airport and you have time waiting for your flight, a bunch of airports now have the little CPR machines where you can go over and do a couple chest compressions and see how your chest compressions are and stuff. Totally recommend that too. They have nice little screens that walk you through the whole process. So when you do CPR, your goal is to push hard and push fast. You're aiming for a depth of 2 inches into the chest and you're aiming for a rate of between 100 and 120. Staying alive is the beat that we aim for, okay? Or another one bites the dust. Is that part of staying alive? I don't know, I can't think. Again, that's probably before you guys, isn't it? I have a whole CPR playlist on Apple Music. But if you Google songs to do CPR for, you'll get all the songs that have a backbeat between 100 and 120. And then you're gonna check a pulse every 2 minutes and you do a full 2 minutes of CPR before you stop and you check a pulse. The other most important thing is going to be early defibrillation, because if the patient has an abnormal heart rhythm that's causing them to not push blood forward, you need to get them out of that rhythm. And by sending electricity to the heart, you essentially stun the heart and stun the myocytes, the muscles in the heart, which allows them to sort of reorganize their native electrical rhythm and get it back on the right tracks. Okay. When we defibrillate patients, we have pads and we usually put them on the anterior of the chest and the posterior of the chest. So you might see us roll the patient and slap a giant sticker on them, or we put it anterior and lateral. And the way these pads look are like this gentleman. I brought a couple examples that you guys can pass around.
Sort of see.
I don't recommend taking the stickers off because they are ridiculously sticky. But I brought a set of kids pads and I brought a set of adult pads. They're expired, so don't feel bad for not missing anything. But you can see sort of how they look. So you open them up. This gets plugged into that machine that's on that blue cart that was sitting over here. And then we have these pads. You peel them off and the sticker tells you exactly where they go. And peel it off. Sticker tells you exactly where they go. You can peel it back and They're really, really nice. They're a little slimy and a little sticky. That's because you need good contact with the skin to make sure that you don't burn the patient's skin and that the electricity actually goes all the way through to their heart. This little thing right here actually tells you how good your CPR is. And if you see up here, you see this diamond and you see this square. So the diamond will get all the way full when you're going at an appropriate rate and an appropriate depth. And the little square goes up and down. So all the way colored in when you're pushing down, and then all the way clear when you release to show you that you're giving full release. Okay. So I will pass these around so you guys can kind of see what they're like. You get to rip that one open. Have fun. And then this is showing the whole CPR. This one right here showing that you've got good cardiac perfusion because your CPR is good. And then this one right here showing that you have release. And then you can see the rate shown as well at 101, which is excellent. We want between 100 and 120. And then you can see the depth at 2.3 inches, which is also excellent because we want a good depth. All right. I'll send out a link. There is a app. Reshare this one, share. There's a fun little app. I think it's from the University of Florida. That's like a fake online defibrillator so that you can kind of see it and sort of see what goes into it. You click the start, it runs through their little like study thing that they're doing with it. And then you can select where you're going to put the pads. And so I'm going anterior lateral. So I'm putting one directly on the center of the chest and one over the left side of the chest. I don't want my pads to touch, but I do want my heart sandwiched between them. And then it will let you, the next one basically shows you the defibrillator and you can turn it on to a monitor mode, or you can turn it to a defibrillation mode if we think we're going to have to defibrillate the patient. You can see your energy that you select here. This is how many joules, how much electricity we're going to shock someone with. There's an analyze button. If one of the residents ever pushes this, you will see me yell at them because they're a doctor and they should not be using the analyze button. They should be using their brains. There is a charge button, and then this is the shock button. And you guys will hear us before we shock a patient say clear, and we want everybody to step away from the bed and not be touching the bed so they don't get shocked as well. On the center of the screen, you'll see the rhythm that's going on, and we'll talk a little bit about the different heart rhythms. And then you'll see the rate up here also. Right here is the joules that we're going to defibrillate at. So I'm going to take that from 120 to 200 by increasing my energy up here. And then when I am ready to charge, I get to hit the charge button and the machine's going to go woo. I did that way too fast. Still charging. Now it's ready. And then it's going to beep that it's ready. The shock button is going to glow, and then you get to hit the shock button, and it's going to deliver a shock and hopefully put the patient back in a better rhythm. All right. That's the defibrillator. I'll send this out so you guys can go through it and kind of play with it if you want to. It's pretty cool. Yes.
How many joules should be using?
So 200 for most things when patients do not have a pulse. Occasionally we use a slightly different amount of joules, amount of energy if they do have a pulse, but 200 if they don't have a pulse. Yes.
If you open up the chest, you shock the heart directly.
Yeah. If you open up the chest and shock the heart directly, you have these two little pads that you're using. This will happen in the trauma patients. If we have blunt or penetrating trauma and the patient, blunt meaning like something hits the chest, like a car accident, penetrating meaning something goes into the chest and opens the chest up, like a gunshot wound or a knife, or a large tree that they fall on, or something like that, that actually penetrates through the chest and we end up opening up the chest. We will do that if the patient has been down, meaning they lost their pulses for a certain amount of time. For blunt trauma, usually once they pass the 5 to 10 minute mark, the chances of you getting them back and getting someone to survival are pretty much zero. For penetrating, once you pass the 10 to 15 minute mark, the chances of survival are zero. But we will on occasion open up a chest, in which, what I mean by that is we'll make a big incision along the entire lateral left side of the chest. We'll open up the muscles between the ribs. We'll open up the entire chest, and then we will go in and we'll do open heart CPR. Instead of pushing on the top of the chest, we push directly on the heart. And then if it is an abnormal rhythm there, then we have these cute little metal pads that look like giant serving tongs. that you stick into the chest, you put directly on the heart, and you shock usually at around 10 to 20 joules, much, much lower because you have direct contact. Yes.
Depth and strength.
No. What you do is it's essentially like having a water balloon in your hand. You put your hands with your palms, the heels of your palms together, and then you just swish forward like this. And if you've done anatomy, the ventricles of the heart, the lower portion of the heart, it's kind of sit in like this area. And the reason why you put your heels there is because essentially my heels are going to go like right here, and I'm going to push everything up and out of the ventricles. Okay. And so that's why it would be like this. Okay. Lots of fun. You still aim for a rate of 100. Yeah. All right. So little bit of physiology. If our heart is not pushing our blood forward, we have no pressure of the blood in our body. So you can think about it as a garden hose. All right. If the garden hose is not turned on, there's nothing coming out of the garden hose. All right. If you turn the garden hose on, it's going to take a few seconds for all that water to get to the end of the garden hose and get water flowing out of the garden hose. It's the same for our heart. So if nothing is happening and no one's pushing on our heart, nothing's happening. We aren't getting any blood circulating. All right. But the second we start doing CPR, we start pushing that blood through the body, and we'll work up to getting a pressure in the body. Now, when we stop CPR, we turn that garden hose off, and you lost all your pressure. Okay. And it's going to take you several compressions, just like it does when you turn on the hose. It takes a few seconds to get water out the other end. It's going to take you several compressions to get a perfusing pressure again. And so we try to minimize the time that we stop CPR. So when we do a rhythm check or a pulse check every 2 minutes, we stop CPR. But every time we do that, we lose our perfusing pressure. And so some fancy things that you might see done is you may see people pre-charge the defibrillator in anticipation that if there is a shockable rhythm, and we'll get to those shockable rhythms here in a few minutes, that you're ready to go and you can immediately shock and get right back on the chest. Or you may see people stop, do a pulse check and a rhythm check, see that the rhythm's shockable, get right back on the chest and do CPR while the machine charges, and then have everybody step away to shock. That is to make sure that we have like the best perfusing pressure possible. All right, airway stuff. So that's what we're doing for the heart. In the meantime, we need to make sure that we're giving the person some oxygen and we're helping them blow off CO2. We have a whole bunch of different things that you guys will see. You'll see nasal cannula. That's just like a cute little prong that goes in the nose. We can give a couple liters of oxygen through that. You'll see a simple face mask. You'll see the face mask with the big bag. That bag is a reservoir of oxygen. And when they breathe in the oxygen through the bag, but then it has a one-way valve on it. So when they breathe out, everything that they're breathing out gets pushed out of the mask. And then they breathe in the bag, push out of the mask. All right. Oops, sorry. You'll see us put in oral airways. This is this little red C thing up here. This slides into the back and down the back of the throat to open up all of that soft tissue and basically act as like a little straw to open it up. So that when you bag them, when you put the big mask over them and you squeeze on the bag, the air can go in. You'll see us put in nasopharyngeal airways. That's that cute little green one. It just goes straight in the back of the nose and ends up sort of sitting down in the back of your throat. And then this one right here is the BVM. And I brought one of those. Well, and these mannequins are fully intubatable, so you can access those as well if you want to. All right, so here's the BVM. This gets connected to the oxygen wall. This goes over the patient's face. The pointy part goes up at the top of the nose. The part goes down underneath their chin, so it connects to the face pretty well. And then when you squeeze, you just do a nice squeeze and release. And this will be filling up with oxygen from the wall, which is really nice. This is one of the oral airways. I'll pass this around so you guys can see that. Have a BVM to play with. I think they have a nasopharyngeal airway. Oral airway, just so you guys can kind of see what they're like. Then there's BiPAP and CPAP. This is like the CPAP is the mask that people who snore really badly wear at night. BiPAP is just a fancier hospital version. This provides some positive airway pressure, meaning you're pushing air into the lungs to help sort of prop the lungs open, okay? When we all breathe right now, we're breathing negative pressure, okay? And so what I mean by that is our diaphragm, the muscle that sits in our chest, contracts and tightens, and it drops down. And when it drops down, the air rushes into our lungs, all right? It creates a negative intrathoracic pressure and air rushes in. Versus when we do the BVM, or when we put a breathing tube in someone, we are positive pressure. We are shoving air into them, okay? That matters because when you shove air into something like the chest where the heart is, it decreases the amount of blood that goes back to the heart. So if you ever take a physiology class, you will learn a whole lot more about this and why it really, really matters. And then sometimes we will put an endotracheal tube, endo meaning in, tracheal meaning trachea, a tube all the way down into their trachea. It'll sit at the carina, which is the part where your trachea splits into two main bronchi. And we will be able to oxygenate and ventilate the lungs that way. ET tube. Feel free to open them. You go to ET tube. At one end, you will see a little plastic piece. This little plastic piece connects to the BVM, that mask that sits on the face. We pop that off, and then this will connect to it. And that's how we bag the patient through the ET tube. There's a little balloon at the other end that gets inflated with like 10 cc's of air. That way it blocks off the entire airway. And it sits like right like that and gets completely blocked off. That way nothing can go back down into the lungs. Questions so far? Are we doing okay? Okay, is this cool or am I boring you? Okay, cool, just making sure. I don't want to bore you guys. So when we do the mask, a lot of people think about like pushing the mask down onto the face to get a good seal, but what you actually want to do is you want to lift the face up into the mask. If you think about like how you're normally sitting with like your neck kind of elongated and everything, but then you lay me down and you put a board behind me and you shove the mask onto my face, I'm going to block everything off here and then I can't breathe. Okay. So you want to try and pull the face up into the mask. It'll elongate everything and make it a little bit easier to breathe for the patient. It's tiring. Your hands get really, really tired. Yes.
For jaw patients with the C-collar, would you do the same, like lifting up the neck?
Yeah. So it's really interesting because if you do it right, you're not really moving their neck. What you're moving is their jaw. So if you put your fingers behind the angle of your mandible right here and you sort of relax, you can gently push the angle of your mandible forward. Don't go like crazy and force it, but like, and that's really what you're doing. And when you do that, you help slide the tongue out of the way and you open up their posterior oropharynx, the back of the throat, and you sort of help open up a lot of that tissue to make it easier to breathe for them. So when you do that little C and E grip and you're pulling the face up in, you're really just pulling the jaw up to open things up. So this is just an example of like the C between your thumb and your first finger, and then the E are your third, fourth, and fifth fingers grabbing behind the jaw and sort of lifting it up into there. There've been a lot of studies that tell you like when we should put in an endotracheal tube or like an LMA or something else. And a lot of the studies have actually said that it's better to just keep bagging your patient. We get really, really excited about intubating people in the emergency department, which sounds kind of terrible because people are having a bad day. But this is our job and we like fun things. And I don't want bad things to happen to people, but if they're going to need an intubation, I'm happy to be there. But realistically, bagging them is probably the better option. And part of that is because people will oftentimes hold chest compressions to get an ET tube in. And as we talked about previously, CPR is one of the most important things we can do, and we don't want to lose our cardiac perfusion pressure. There are a few advantages to putting an ET tube in. You have a little bit better job of like oxygenating and ventilating them because you have a direct straw down into their lungs. You also have the ability to protect their airway because that balloon then inflates. And if that person's vomiting up a lot of stuff, it's unlikely to go back down into their lungs. Or if they have like a lot of blood coming up, by putting the ET tube in and inflating the balloon, you prevent the blood from going down into the lungs. Funny side story, when I was a third-year resident, so several years ago, we had a really sick trauma come in and he started to vomit, and traumas come in and they're on like a backboard and they have a C-collar on so they can't move their throat and we don't want them to move. And so we all grabbed him and we rolled him up onto his side so that he could throw up off the side of the bed. He very generously threw up into my cargo pocket and filled it with vomit. It was gross. I was not happy. I'm also a sympathetic vomiter. So as he was like actively puking and my cargo pocket is like filling up with his warm, gross vomit, I'm like sitting there and I'm like, as I'm like holding his neck and trying to be like protect his C-spine, and he's filling my pocket with vomit. And I'm just like, why am I doing any of this? Yeah, good times. Yeah, that's all. That was my story, you guys. There's not much more to it. Other things we'll be looking at is we'll be watching their end tidal CO2. So we breathe in oxygen. It goes to our blood. It gets diffused to our entire body because our blood circulates it around. All of our cute little cells do their metabolic thing, and they use up the oxygen and they send out CO2. That comes back in our blood up through our lungs, and then we breathe out that CO2. So we can follow the end tidal CO2 to determine how well this patient's doing. So if all of our blood is circulating well, we're oxygenating well, bringing in good oxygen, all of our cells are doing their job and turning that oxygen over to CO2, do we think we're going to have a high CO2 when we blow it out or a low CO2 when we blow it out? So it's probably going to be high if all of our little cells are doing their jobs and using up all that oxygen and kicking out CO2. If our heart is not working and we are not pushing blood around well and we do not have good oxygen, do we think we'll have a high CO2 or a low CO2? Well, low, because we don't have any oxygen that's getting circulated for our cute little cells to do their job and change it into CO2. So on the monitor, we'll have an end tidal CO2 monitor, and we can measure the amount of CO2 that's coming out of that person. And if their end tidal CO2 is less than 10, that's really bad, okay? If it's greater than 40, we're probably all greater than 40 right now, okay? That's a good thing. So if the end tidal up on the monitor is less than 10, it tells me a couple things. It tells me that maybe our CPR isn't adequate and we need to do better CPR. It tells me that maybe our oxygenation is not adequate and we're not providing enough oxygen to the blood to circulate around the body. Or it tells me that maybe this person is deader than dead and we're not getting them back, okay? If our CO2 is, if our end tidal CO2 is around the 20 to 30 mark, that tells me that we're probably doing high quality CPR. We probably have good oxygen coming in. And so we're circulating things around to the cells in the body, and they're having the opportunity to pick up that oxygen, metabolize, and kick out some CO2. And that's good. We want that. We're perfusing well. When it gets above 40, then I think we probably have native heart function back, because no matter how good my CPR is, it's probably not as good as that person's native heart. So I'll finish out my 2 minutes of CPR. And then I'll check for a pulse, and I'm going to guess that I'm probably going to have a pulse back. All right. So we've done our circulation. We've talked about airway things. We've talked a little bit about breathing. IV, O2, and monitor. We've got them up on that. And now we need to get the story. Okay. Because this is where we can really make a difference, is figuring out what is going on and how we fix it, how we reverse it. So the algorithm, if we go all the way back to that big one that was like the giant chart of everything branching off and what we do, it really comes down to a few things. It comes down to 2-minute cycles of CPR, stopping and checking for a pulse and checking for a rhythm. It comes down to breathing well for the patient, delivering them oxygen. And it comes down to giving the right medications and shocking if it's time to shock. While we're doing all of that, you'll oftentimes hear us having a conversation about the H's and the T's. The H's and the T's are the reversible causes, things that we can have an immediate effect on to fix for this patient. Your H's are things like hypovolemia, meaning low volume in their blood system. If someone's puking a lot or has a lot of diarrhea, they're going to deplete their volume pretty quickly. If someone is hemorrhaging, having a lot of bleeding, in the case of like a GI bleeder who's throwing up a lot of blood or pooping out a lot of blood, or someone who has a trauma, they need blood. Hypoxia, low oxygen levels. We'll be able to tell that by the oxygen probe on their finger, but then also realistically, we're fixing it because we're breathing for them. Hydrogen ions is acidosis. Patients who are septic have really, really bad infections that are affecting their whole system will get very acidotic, and your body does not like it when you branch out from your normal pH. It doesn't like being acidotic. It doesn't like being alkalotic. Also, patients who are end-stage renal disease and are getting dialysis, if they miss dialysis sessions, can get acidotic. patients who are diabetic and go into something called ketoacidosis, acids in the title, which is really nice. They can get acidotic too. We think about their electrolytes being abnormal. Your heart really dislikes it when your potassium is too high or too low. And then we think about patients who are too cold, more common in the Midwest and the East Coast during the winter times, but hypothermia is a thought as well. For the T's, we think about tension pneumothorax. This is when one of your lungs collapses and you get too much air in that space of your lung, and it pushes everything over because you have too much air in that thoracic cavity. We think about cardiac tamponade. Your heart is basically sitting inside of a balloon, and you can get fluid outside the heart, but within that balloon. And it reaches the point where the balloon can't stretch anymore. And then that pressure causes your heart to not be able to fill. We think about things like toxins, so overdoses, accidental or intentional. We think about thrombosis, so a very large clot in the lungs or a very large clot causing a heart attack. These are all the things that we can quickly do something about and we can reverse while that patient is sitting in front of me. So if you're ever with me, you'll hear me ask the patient to go through the H's and T's, tell me what they are, tell me what we're doing to fix it. And then before I ever call a code, I do the exact same thing again. We run through all of them out loud, everything we know, anything that we possibly could have changed, and we go through that information. We can go into them a little bit more. All right, here's our algorithm. There are a couple heart rhythms that we look at. We've got pulseless electrical activity. We've got asystole, we've got ventricular fibrillation, and ventricular tachycardia. I'm going to go through each of these. But before we get started, I want to see where we are in terms of how the heart works. So I'm not going to ask questions. I'm just going to explain. Okay, so you have 4 chambers in your heart. You have the atria, which are the top portion, and you have the ventricles, which are the bottom portion. The right side of your heart pushes blood towards the lungs, and then that blood comes back from the lungs and goes into the left side of your heart and gets pushed out to the entire body. Okay, so the right atria gets the blood from the body and pushes it into the ventricles, the right ventricle. Then it goes from the right ventricle out to the lungs, comes back to the left atria, to the left ventricle, and then out through the body. Okay. There is an electrical system in the heart, and that is what gives us those little rhythms, the squiggly lines, or EKG or ECG rhythms, is it has to do with which areas of the heart are basically like depolarizing or repolarizing and how that's happening. The SA node is the area that starts the electrical activity. There's the AV node that's in between your atria and your ventricles, and it pauses things for a hot second before it lets it go down through the ventricles. Okay. So different rhythms mean different things. Normal sinus rhythm means your atria are contracting together because the electrical activity is starting in the SA node. It goes out through your atria contract, and then it goes, the electrical activity goes down through your ventricles and your ventricles collapse, contract. Okay, that's normal. So the dance would go like this. Totally normal. Okay, this is good. I expect this. This is what we are probably all doing right now. All right. Now you can have electrical activity, but not have it be strong enough to make your heart do anything. Okay, and that's pulseless electrical activity. So when you look on the monitor, it's going to look normal, but you won't be able to feel a pulse. There's 2 reasons. Either it's not strong enough to make the heart do something, or the blood pressure is so low that you can't palpate the blood pressure. Okay, and that's part of the reason why you guys are doing the carotid study, because the blood pressure may be 40 over nothing, and you may be able to see the carotid pulsing on ultrasound, but I might be palpating and be like, I can't feel anything. When the reality is the patient does have some cardiac function and they do have a blood pressure, we just can't feel it. So this is PEA. All right, there's electrical activity happening in an organized manner, but it's not doing anything. All right. An agonal rhythm or asystole means that there's really not any good electrical activity happening. This is that flat line. Okay. For these patients with PEA or an agonal rhythm, really all you do is CPR and epinephrine. These cannot be shocked. I guarantee you have seen someone on TV shock both of these rhythms like 1,000,001 times. They can't be shocked. There's no point in shocking them. It's not going to do anything. Probably not going to hurt the patient, but it's not going to do any good. And so for these 2, it's just high quality CPR and epinephrine. All right. Now, The other two that we're going to talk about are ventricular fibrillation and pulseless ventricular tachycardia. Okay. In ventricular fibrillation, instead of the ventricles getting the electrical activity from your AV node and then going down through your ventricles and causing them to contract, the ventricles have a bunch of different areas that are randomly just starting off with electrical activity, and nothing of any importance is happening. Okay, so we've got my atria up here, we've got my ventricles down here. They are basically just going like this. Like nothing is going on. My atria might be doing something, but they're not doing anything useful. And if you think about the difference between a nice organized like collapse going on versus just like wobbly legs, this is not going to send anything anywhere in the body. Okay, so it's not going to generate a pulse whatsoever. This is an abnormal electrical rhythm. Again, it's basically starting in a bunch of different areas in the ventricles. So we need to shock this, turn it off, and hopefully let it turn back on again on its own. Does that make sense? Cool. All right. Ventricular tachycardia is just a little more organized than ventricular fibrillation. Okay, so it's making a little bit more of a dance that makes sense. It's doing probably a little bit more of like this, just really fast. And if we're going too fast, we don't have any time to get blood back in to fill up enough to send it out to the body. Okay, people can have a pulse with ventricular tachycardia because they're filling it up enough and they're sending it out enough and getting a high enough pulse, but you can also have it be pulseless because it's just moving so fast that you can't fill anything out. VTach will often be going at a rate of around like 150 to 200. So very, very, very fast. Yes.
Shock VTach if they do have a pulse.
Yes, you can if they're unstable. Yeah. I'm not getting into the like live patient stuff, but if you ever want to, we totally can talk about it. But for your patients that have ventricular tachycardia with a pulse, ventricular tachycardia can have a pulse. But if you have those patients that do have a pulse and they are unstable, meaning their blood pressure is really low or they're confused or something, you can totally shock those people. And then we have polymorphic ventricular tachycardia or torsades. Yes. In terms of causing people to go into these abnormal rhythms? Yeah. Yeah. So if they're pulseless, they absolutely won't have a blood pressure whatsoever. If they are in ventricular tachycardia and they have a pulse and their blood pressure is high and they're awake and talking to me, then I try to give medications to get them out of this. I try to chemically stop and restart their heart or pause their heart and let it reorganize itself. If their blood pressure is really, really low or they're really confused, then I will just shock them to stun the heart, stop the electrical activity, and try and get it restarted up again. Okay. Long-term high blood pressure, basically your heart is working really hard. It's like a bodybuilder then, right? It's trying to push against this high blood pressure in your body. And so it has to work really hard and the muscles have to work really hard. Eventually those muscles get tired and then they stretch out, and then that electrical system that they go on gets stretched out and it's not the same as it used to be. And that can cause people to go into abnormal rhythms. Yes.
What does the shock feel like?
Terrible. Like you're being kicked by a horse. Patients do not like it. If you can, if they're dead, they're dead. They're not going to feel it. I realize that it sounds really callous to say, but they're dead. They're not going to feel it. If they're alive and they have a pulse, we try to give them some medication. We try and give them some pain medication, usually something like IV fentanyl, because IV fentanyl doesn't affect their blood pressure as much. Now, the stuff we have in the hospital is not the street stuff. Okay. It's much better. So it's going to help with the pain control. And then we usually give them a benzodiazepine, a benzo like an Ativan or a Xanax, an IV form similar. We use Versed traditionally in the emergency department, midazolam. And that's really nice because it causes a little bit of retrograde amnesia and sort of makes them forget about things that happened a few minutes ago before you gave it. So I had this cute little old lady several years ago who came in an abnormal rhythm that we needed to shock to get her out of. And she was unstable. Her blood pressure was very low. Her daughter actually happened to be a cardiac nurse, which was great because that meant I really didn't have to explain too much to the daughter because I really just wanted to shock her as fast as possible. And the patient was like, not really following commands, like kind of moaning and groaning and like wouldn't really open up her eyes, but was like pulling her arms away when you poked her and that sort of stuff. And the daughter was like, I completely understand, just shock her, it's fine. And I was like, okay, thanks, perfect. So we charged to 200 joules and I shocked her without sedation because she was that unstable and we were concerned about her. It got her out of the rhythm. She was very upset with me because it hurts a lot. Has anybody ever accidentally leaned against like a horse electrical fence? Yeah, I totally did that. I woke up on the floor. Feels terrible. She basically cussed me out. Like this cute little 80-year-old lady had a slew of language that I was like, go you. And it was like, I don't like you, you're mean, how dare you? Her daughter and I were like, you're alive, yay, go us. And then I gave her a dose of Versed, and like 5 minutes later, all she would do would be like, give me the stink eye and be like, I don't like you. I don't know why, but I don't like you. And I was like, I know, it's cool. Don't worry, you're alive. So it gives really great retrograde amnesia. It'll help people forget. So if you have the opportunity to give them pain meds and some benzos prior, awesome, do it. If you don't, give it immediately afterwards to help them forget the situation and forget that you just shocked them. Yes.
One time, one of the ultrasound fellows performed a ganglion block.
Yeah.
Like, do you know why? I asked, but I kind of forgot exactly the reason. They were kind of also in a rush, but it was during a code. It didn't work. I'd like to mention.
It is in the tip of my tongue as to why, but it's not coming out right now. I will look it up and send it out in a follow-up email for you guys. Yeah. Yes, it's 100% right there and it's just not jumping forward.
There you go.
Yeah. Other questions? Yeah.
Pulseless, what were the pulse?
Realistically, the big thing that's happening differently is their heart's just not filling up with enough blood to push out to the body, or the electrical circuit's going, but it's not enough electricity to make their heart actually squeeze. Versus if they are having a pulse, then they probably have enough blood coming back in. That way they have blood to push out. Or, I mean, either way, yeah, the electrical activity is enough to make it squeeze and they have enough blood coming in to push it back out.
Okay.
Other questions? Okay, cool. Torsades is just a special type of VTAC. It looks like a little ribbon that's being like twisted, is how people explain it. It's due to a channel issue in the heart, like the channels are not working properly, so you get a special type of ventricular tachycardia. This never has a pulse. This is always dead. You always have to shock this, and you're always going to give magnesium to try and help fix it. Okay. Dead people medications. Epinephrine. You guys are going to hear us talk about giving epi all the time. Epinephrine is a non-selective alpha and beta agonist. It is going to increase your peripheral vascular resistance, make all of your little tiny blood vessels clamp down and push blood back up towards the heart. It's going to increase the heart rate, and it is going to increase your cardiac output, the amount of blood that is being shoved out of your heart. Okay. It will hopefully maybe restart your heart. We give it to PEA, pulseless electrical activity, asystole, pulseless VFib, pulseless VTAC. The other medications that we might use are essentially like chemical electricity is the way you can think about them. Amiodarone and lidocaine would be the other ones. They block certain channels in the heart, thus trying to pause that electrical activity that's inappropriate and allow the heart to sort of restart up on its own. Okay, you can think about this as like turning your computer off and on again in hopes that it does its job appropriately. Epinephrine, all of our code drugs come in these fancy boxes, which is really nice because it makes dosages really easy. They come in nice little boxes, you rip them open, and then you can give them. In this box, we have lidocaine, calcium, atropine, dextrose, and sodium bicarb. We use all of these for different reasons. And then I have some doses of epi that you guys can play with. Two of them have absolutely nothing in them because we already pushed them out, but this is the way the code epi comes. My medication is in this one, and this is the one that I connect to the patient's IV. The two yellow ends get popped off. This is like my favorite thing to do in a code. I get to pop them off and throw them on the ground. And then the blue end goes into the back end here. The two yellow ends go together, right? And then this connects to the patient's IV, and I can push it in, okay? I'll pass this around so you guys can play with it. There is a needle in this. There's a needle on this green side and there's a needle on this back end. These have not come in contact with anybody's blood. Let's continue to keep it that way. 'Cause, 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 you can practice squeezing it if you want to. Sorry. Okay, so that's the epinephrine. There's some other medications that you may sometimes hear us give during codes. There are for very specific reasons to try and make things better. So if a patient is like really acidotic, we may give sodium bicarb, which is going to buffer the acidosis and bring their pH back down to more normal. If the patient has certain overdoses or we're concerned about certain electrolytes may be being abnormal, we may give certain medications like calcium to try and stabilize the heart and help it be less irritated by these abnormal electrolytes. And then anytime you give a medication, keep doing your CPR because you need to actually circulate that medication through the body. That's our whole little circle. Now, everything occurs kind of on its own timeline. So your CPR occurs every 2 minutes. Your epi occurs every 3 to 5 minutes. If you are shocking a patient, you shock for those rhythms that are shockable and you don't shock for rhythms that aren't shockable. And then your amio or your lido, your antiarrhythmic medications, they occur on their own timeline too. So it can get really, really confusing if you're thinking about every 2 minutes, you stop to do a pulse check and a rhythm check. And then every 3 to 5 minutes, you're giving a dose of epinephrine. And then every 3 to 5 minutes, you can also give a dose of amio or lido. So you kind of have 3 separate timelines that are going on. So let's say somebody loses pulses in front of you. All right. So this is time 0. We are in the room. They suddenly stop talking. We check for a pulse. There is no pulse. They are not breathing. What are you guys going to do? Start CPR. Beautiful. Perfect. How long are you going to do CPR for? 2 minutes. Beautiful. At that 1 minute mark, that poor person is still doing CPR, high quality chest compressions, rate of 100 to 120, a depth of 2 inches. They're getting a little sweaty. They're getting a little tired. They wish they'd taken their white coat off and taken their stethoscope off because it keeps flipping up and hitting them in the face. That person is me. That's what happens every single time. At that 1 minute mark, somebody hands you the epi, you go ahead and give it. All right. We continue to 2 minutes. At 2 minutes, you stop your CPR. You look at the rhythm. You look to see what rhythm it is on the monitor. You palpate for a pulse. You guys are up there getting a carotid ultrasound and you're like, I'm not telling you what's going on. You tell me what you feel. And then if we don't feel a pulse, what are we going to do? Continue CPR. Perfect. All right. At your next 1 minute, nothing happens because we still need to finish out a minute of CPR and we only gave a dose of epi like 2 minutes ago. So we just keep going. At minute 4, we stop, we check a pulse, we see VFib or pulseless VTAC, we don't have a pulse on the patient, and we say, hey, that's a shockable rhythm. So we charge to 200. We say clear, everybody steps back, we shock the patient, and as soon as we're done shocking the patient, we get back on the chest. Yes.
Charge for it, because if I want to start charging.
It takes like 10 to 15 seconds for the machine to charge. Yeah, it's not like crazy fast, but it's not like crazy slow. So,
charge for a while?
Oh yeah, totally. It stay charged for a while. I usually, if we like get to a pulse check and we decide we don't need the charge, I usually dump it. And in order to dump a charge, you just go up or down 1 joule and that makes it drop the charge. So if it turns out we don't need it, I just dump it until like a minute 45 and then I'll pre-charge for the next one. Yeah, totally. So now we're at the 4 minute mark, which means it's been how long since we gave our last dose of epi? Yeah, like just over 3 minutes, which means we can give a dose of epi. Also, we noticed that we were in VFib or VTAC, which means we can give a dose of amio, amiodarone, which is one of the antiarrhythmic medications that will help the heart get out of this abnormal rhythm. At minute 5, there's nothing to do. We just sit there. We talk about our H's and T's. We talk about what we're doing to try and fix the situation. At minute 6, we've now done another 2 minutes of CPR. So we pause. We do a pulse check. We do a rhythm check. We have no pulse. We have PEA or asystole. So what are we going to do? We're going to do some CPR and keep going. All right. Minute 7, it's now been, it has not been 3 minutes. Wow. My amio and lido are a little early. Someone needs to yell at me. It's only been like 1, 2, maybe it's kind of been 3. We can give our second dose of amio. At minute 8, we stop for our next pulse check. You're starting to get the hang of this. It's very rhythmic. You do the same thing, the same waltz over and over again. You're in VFib, pulseless VTAC, or torsades, which means we're going to do wet. Shock the patient, beautiful, charge to 200 and shock. And we continue on and on and on. Every 2 minutes, we stop for a pulse check and a rhythm check. If they don't have a pulse and the rhythm's shockable, we shock. If it's not shockable, we don't shock. We give epi every 3 to 5 minutes. We give our 2 doses of amio 3 to 5 minutes apart. And we continue on until we either get a pulse back or we decide we're done. All right. So what do we do with these different things that we can potentially change? Hypovolemia, you have IV fluids. If you think they're just fluid down because they've been puking everything up or had massive diarrhea. If it's trauma, we'll give blood. You guys will see us pull whole blood out of the fridge and call for blood to come from the blood bank. If it's hypoxia, we give oxygen. So we intubate them, we give them oxygen. If it's acidosis, because they're septic, we give sodium bicarb to buffer that acidosis. If it's hypo or hyperkalemia, we treat hyperkalemia with calcium, sugar, and insulin, because that actually pushes the potassium into the cells and hides it away for a few seconds. If it's hypokalemia, because they've been puking a ton, we can give them IV potassium. If they're cold, we warm them. If they have a tension pneumothorax, which you might see in trauma patients, we'll put a needle in their chest and release that pressure. If they have cardiac tamponade, you may see us put a needle into their the pericardial sac around their heart and try and pull off that fluid. If it's a blood clot in the lungs or in the heart, we may give a medicine to break up those blood clots. And we continue on every 2 minutes until we decide we're done or we get a pulse back. All right, questions? Yes. Yeah, so when do you call it? Like, that's the hardest part. Traumas are a little bit easier to call because we know we have good data on past certain times. Like we're not going to get a pulse back. We're not going to have a good neurological outcome. There's 2 things I think about like when I'm calling it. I think about like whether or not the opportunity to get a pulse back is there, and then what type of life that person is going to have if they do get a pulse back. So are they going to be able to walk out of the hospital neurologically intact and care for themselves, or are they never really going to wake up because their brain didn't get enough oxygen for a prolonged period of time? The longest codes that I've done have usually been very young people, where I knew what was going on and we had an idea of how to fix it. So an overdose that you decide to put in a dialysis catheter and dialyze while you're doing CPR. I think that one ran for about 2 hours. While they got the catheter in, they called nephrology. Nephrology brought in a dialysis machine. They dialyzed for an appropriate amount of time that they got all of the overdose toxin out. And then they still didn't get a pulse back and they said, okay, we're done. If you think that it is a blood clot in the heart or a blood clot in the lungs and you decide to give the medication to break up that blood clot, you've committed your team to 90 minutes of running this code after you give that medication, because you need 90 full minutes to circulate that medication enough to break up that clot enough in the heart or the lungs to hopefully open up that pathway and get their heart moving again, get the blood flowing again, and potentially get pulses back. Most of the time when we run a code, we're looking at somewhere between 30 minutes and 45 minutes, and then we're calling it. Yeah.
So you give them a medication to open up the clot and they get ROS. They lose their pulse again. Does the 90-minute reset?
No, it's 90 minutes from the time of the medication. Yeah. So like if we've been going 45 minutes and then we get a pulse back and we all high five and we're super happy, and like 20 minutes later they lose their pulses, I'm calling that 65 minutes. And I'm probably going to go to the full 90 minutes. But if it's already been 90 minutes and then they lose their pulses, I'll probably go like another 10 or 15 minutes, depending on how the person overall looks. And then make that decision. So like if their eyes are open and they're blinking during that time where we have the pulse back and they're making purposeful movements, meaning like when I say, give me a thumbs up, they give me a thumbs up, or when I poke them with an IV to get another IV started, they pull their arm away. I'll probably go a little bit longer because they had some signs of good neurological function, versus if we get a pulse back and their pupils are dilated, meaning that they may no longer have like brain activity. In that case, I may call it much sooner if they lose pulses again. Yeah, it's an art. It's not a science. There's a lot of like thinking through, like I said, potentially like what their life will be like, what the chances of actually getting a pulse back and a good meaningful recovery, what you've already done to fix things. I look a lot at like what their pupils are, whether they're moving, whether they're purposeful when they're moving, how old they are, what their underlying disease process is. So like a 90-year-old that has metastatic cancer, that's been undergoing chemo and has been bedbound for 6 months, I'm not going to code them for very long because I'm not going to be able to fix their cancer. They've been bedbound and they're 90. And realistically, the chances of getting a 90-year-old back with meaningful recovery are very low. The chances of getting someone who has been bedbound back with a meaningful recovery are very, very low. And in
Those
those instances, I'm probably not going to go very long because while they are dead, to an extent, I feel like I'm just torturing a body. And I don't like that when I don't think I'm going to get a meaningful recovery for them back. Now, a 20-something-year-old that was throwing up a lot and I don't mean like a little bit, I mean like days or a week of throwing up and threw up all their potassium. I'm probably going to code them for a lot longer because they're young. They didn't have any medical problems beforehand. I can get potassium in them. I can hopefully get them going again. Yeah.
Do the social issues such as advanced directives, DNAR, DNI?
100%. Yes. If someone has a PULSE, a physician order for life-sustaining treatment, it's a hot pink form that may come in with a patient that says DNR, do not resuscitate, DNI, do not intubate, allow natural death. If that rolls in with the patient, the second I see that, get off the chest, stop what you're doing, check for a pulse, we're done. That patient said they did not want to be coded. They made that decision with their physician. I am following that order. Now a family shows up and they're like, no, they didn't mean that. We don't want that. Like, I have to sort of use my best judgment in the situation. If it's somebody that I don't think is going to have a good, meaningful outcome, then I'm going to say like, this is an order and I'm going to follow it because it's the appropriate thing and it is what they wanted. If it's somebody who may potentially have a decent outcome and I may have something reversible and family's absolutely saying that's not what they wanted anymore, I may continue on. Yeah, which gets really, really tricky. Yeah.
So is there ever like a situation where you would like allow a patient to like enter a coma or like not, but then like, I mean, let the see that see
Yeah, 100%. You get pulses back on somebody. So let's say we coded somebody for like 30 minutes to an hour. We don't know what happened. Medics called us. They said they were bringing in a critical ALS run. You guys go check the board. It says full arrest. We all assemble. You're at the head of the bed doing your carotid ultrasound. We code them for 30 minutes. We get pulses back. Their blood pressure is usually going to be really, really high because epi is like adrenaline and it's a massive upper. And so their blood pressure is going to be really high. Their heart rate's going to be really high. We get them kind of stabilized and they've got a good, strong pulse. I've got a breathing tube in them. I'm going to let them hang out there. I probably won't start any sedation unless they start moving things, because I want to see if they're going to move something. If they start moving things and they start reaching for tubes and that sort of stuff, then I'm going to start sedation because I've got a giant tube down their throat. That's really uncomfortable. And very, very probably traumatizing if you can remember what is going on in the future, and probably very scary in that moment. Then I will start sedation. They'll try and figure out the underlying cause, and then they'll try and reverse that underlying cause. Now, if they're not making any movements whatsoever, I'm not going to put them on sedation because I want to see what they're going to do, and I want to see what their neurological function is. If a couple days down the line they're not doing anything, then neurology, neuro ICU will perform a brain depth exam. They'll look to see if their eyes move when you touch their lashes, if their eyes move when you touch their corneas. They'll look to see if they gag or choke when you move the ET tube. They've got a whole bunch of tests that they'll do to see if there is any brain function. If there's no brain function, they wait a couple days, they repeat it again. And if there's absolutely no brain function, then hopefully, we all have our own opinions about this. My opinion is hopefully family will withdraw care and allow that person to finish dying, because they are essentially brain dead, and allow the heart and everything else to stop functioning. If they're an organ and tissue donor, then One Legacy will talk to the family and see if they're open to that. If they're open to that, then they will proceed forward with that. If they're not open to that, then they will allow the patient to hopefully die naturally. Yes.
I know there's like something called locked-in syndrome.
Mm-hmm.
Like movement at all, but the person isn't fully conscious. Have you ever seen it?
Yeah, they can usually blink and usually move their eyes. And that's usually how we start to get concerned about it, is like they're not moving anything, but they're like blinking and they're tracking you. And then I get concerned about potential for locked-in syndrome. You'll usually figure out that that's what they have by getting a CT scan of the head and an MRI of the head to look at the area of the brain that's had a stroke that's caused them to be locked in. Yeah.
About like, I know you said a lot of the time you use your husband.
Mm-hmm. Yeah.
How would you know if you've made the wrong choice?
Yeah. So before I end a code, I have a set of things that I always do. So I let the team in the room know that we're getting ready to end the code. If the patient's family's there, I talk to them and I let them know what's going on. You guys will see us bring family members into codes, and it probably looks like the worst thing you could do in life, but there's actually a lot of data that says that if family members are allowed to be present during the code, and they are allowed to watch and, you know, participate in decision making, they have lower rates of PTSD. Their grief time is less. And the family member tends to do better afterwards. So if family is present, I will talk to them. I'll let them know what's going on. I'll bring them into the room and I'll let them participate in the code. When I get ready to stop a code, I let the team know. So usually I will say something like, all right, at this point in time, we've been resuscitating this patient. We've been running a code for 45 minutes and we have no changes in rhythm and we have no signs of life. So I'll start with that. Then the next thing I usually say is, this is what we know, and I'll give a little synopsis of the story, and I'll say, this is what we've done for the patient, and I will verbally go through all of my H's and T's. We have intubated the patient, and we are giving them 100% oxygen, so we have corrected, hopefully, any hypoxemia. We're giving high-quality CPR, giving them 3 liters of fluid to correct hypovolemia. Their HemoQ, their bedside blood test to see if their blood was low, was normal, or it was really low, so we gave them units of blood. We did an ultrasound. There is no sign of any tension pneumothorax. They have good lung sliding bilaterally. There is no evidence of cardiac tamponade. We do not see any fluid around the heart. I have no reason to believe that this patient would have thrown a pulmonary embolism. They do not have any risk factors. Their initial EKG did not show a STEMI. I don't think that this was a thrombosis of the heart. Their temperature is normal. They're not hypothermic, or they are hypothermic and we've been warming them up to a set temperature that you try to get them to. Their ABG showed normal electrolytes, or it showed abnormal electrolytes, and this is what we do. And after I run through all of those, the next thing I say is, does anybody else have any suggestions or ideas? And I wait and I see what other people suggest. Sometimes someone on the team has a really good idea and I'm like, oh my gosh, I'm an idiot. I can't believe I didn't think of that. And I'll be like, yeah, let's go for it. Usually they've spoken up before we've reached that point if they have an idea. Sometimes people will have ideas where I'm like, no, that's not a good idea at all. And then I'll gently explain why. I'll be like, you know, I don't really think it's the best idea to give this patient potassium. Their potassium level came back at 7, so that's pretty high. So I don't want to make it worse. We actually gave some glucose and some insulin to try and drive the potassium intracellularly and some calcium to stabilize the myocardium. And I'll go through, and if anybody has any ideas, we'll talk about them. And then if we've addressed everyone's ideas and we still don't have any signs of life, no heartbeat, no pulse or anything like that, then I will again let the team know that I'm getting ready to call the code. And I will say, I think that we should probably stop the resuscitation on the next pulse check. Do I have any objections? And I will wait for people to give me some objections. And if they have an objection, we'll talk about it, we'll discuss it. If no one has any objections, I confirm again, are we all in agreement with stopping the code at the next pulse check if there are no signs of life? And if everybody agrees, when we get to the next pulse check, if there is no pulse, we'll do a quick ultrasound of the heart. If there's no cardiac activity, then we will stop. When we do stop, I usually allow a moment because someone died and that someone belonged to a lot of people, I'm sure. And so I usually give a little moment and then I go around and I thank everyone in the room because that was a lot of physical effort, a lot of emotional effort, a lot of heart and soul that goes into that situation. And I'll thank everybody for what they did. I'll ask if anybody has any questions. And if we have time, I'll try to answer them. Sometimes in the emergency department, there isn't time. And sometimes it will be, I am so sorry. If anybody has any questions, please find me a little bit later on and I'll be happy to talk about them. If anybody wants to talk about this at all, like find me with chat. But I have another critical trauma to get to and someone else is trying to die, so I have to leave right now. And then I'll step out. Yeah.
Is the time of death called like at the last pulse check?
Yeah, it's called the last pulse check. Yeah. So when I say, all right, we're stopping at this next pulse check and we stop, and there's no pulse and there's no cardiac activity on ultrasound, then I would say time of death 5:46. That is a great point, right? Because their heart stopped, they're dead at that point in time. I don't know. We call it when we, I guess so. Yeah, I honestly don't know, but we call it when we do our last pulse check. But you're totally right because they died like, you know, 45 minutes ago or 30 minutes ago or 20 minutes ago. Like that's when their heart stopped. That's when they died. But we call it when we do the last pulse check. I'll look into historically why that is, because that's an interesting question. Yeah. Other question?
Like legally.
Yeah.
Those complications that might arise when you're like saving someone's life, and also what kinds of like protective measures are set in place to protect.
Yeah. Yeah. So, if you're out on the streets and something happens, Good Samaritan law protects you as long as you are acting within your scope of practice, meaning it is something that you are comfortable doing and have appropriate training in doing. Within the hospital, I mean, realistically, thinking about things, like anybody can get sued for anybody or for anything, right? Like you guys can sue me right now for standing here. It doesn't mean you're going to be successful. It doesn't mean that a lawyer is going to take the case, but you could file a paperwork and you can try and sue me because I'm standing here with my legs crossed and my hands on the podium. Like you can totally sue me for that. Please don't. But you could. But it doesn't mean you're going to be successful. It doesn't mean that you're going to actually win the case. So in order to win a case of malpractice, you need to have negligence. You need to be not acting appropriately, and you need to have a bad outcome. So there are very set specific things truly to win a lawsuit of malpractice. So if someone rolls in and they have a pulse that says do not resuscitate, and the family is like, I absolutely want you to stop this code, do not keep going. And I'm like, no, I'm going to keep coding them. And we continue on, they can sue me completely appropriately, and they would probably win it for, psychological torture or whatever the appropriate term is that I can't think of right now. Trauma or anything like that. Like they probably could, because technically they told me to stop and we had an order to stop and I kept going. Now, if they don't show up and I never get to see that order and no one ever tells me to stop and I code the person, I'm acting on good faith and best interest. I'm doing what is within standard of practice and care without any further information to know that I should be stopping. So if that person dies and they get brought in and the medics don't bring a pulse and the medics don't say family wants us to stop, and I continue on the code for 45 minutes and then call it, I've acted appropriately. And if family then shows up and is like, I can't believe you did CPR, they were DNR, then I am going to say, I am so sorry, I was not provided that information. And that's that. They can try and sue me, they probably won't win. Yeah. Yeah. If we get the person back and then they're like, I wasn't supposed to be resuscitated. If their next of kin is telling us to go and I don't have anything documented anywhere in the chart that they were DNR, DNI, and that person was made their decision maker, then that person made the decision for them. So like right now, like for example, my husband is the decision maker for both his mom and dad because they're older and they both have dementia and they can't really make their own decisions. If they were both DNR, and we got to the hospital and my husband was like, they arrested, and my husband was like, do everything you can. My husband has power of attorney. They have handed over their right for him to make decisions to them, for them. And so even if they had said they were DNR beforehand, he could change his mind, because he has decision-making power for them. They would be really angry with us if they weren't so demented. We have really dark humor in the emergency department for the newbies. I'm really sorry. Other questions? This is all being recorded too, right? That's terrible. Yeah, what's up?
You said power of attorney takes precedence over like anything they said.
Yeah, because he now has their decision-making power. Yep. I would hope the person that we make power of attorney of us would follow what we would want. My husband will, don't worry. And if he doesn't, I will. And he 100% will. Sorry, that got really weird. Other questions? Yeah.
I have a question about CPR.
Yeah.
Just like, is there any way to do it wrong that could be potentially dangerous?
Yeah, I mean, so if you're doing it wrong, it's probably not like dangerous, but it's not like pulling it. That mannequin's out. I'm gonna go back to that mannequin. So how do you guys so you're gonna put your hands on top of each other. Recommend taking them off. Because otherwise there's gonna be
You're going to put your hands over the patient's sternum, so the breastbone, all right? Usually right in the center of their chest. The heel of your hand is usually going to be right there. usually interlock my fingers, with my heel of one hand over the heel of my upper hand. Everybody always tries to like bend. That this is really hard. But if we fulcrum at our hip, we're going to be able to exert a lot more force and a lot more pressure. So hands locked. Now this table is actually even too heavy. Okay, but you are going to bend at your hips and push down. Right? So push down and release. Push down and release. Okay. So that is what you do for 2 minutes. Okay. As I already started talking about like 10 seconds into it, right? While you're sitting in your mind, and you're also really looking at this patient that you're going to see I sometimes end up looking at their face every now and then. Yours really good, and you're perfusing their brain, and they open their eyes and they look at you, and it's absolutely terrible, and I really don't like it. Depth is appropriate and make sure my rate is appropriate. And then usually our text is on the other side too. Hey, Dr. Ray, you look tired. Get off the chest. Your CPR is terrible. And I'm like, thanks, Sam. But that's very locked directly over the breastbone. Open my hips and pull shoulders go down. Releasing completely. That way you allow time for the heart to refill and pushing down. That way you push the blood throughout your entire body. Okay. As my bun gets loose, my stethoscope is swinging around my neck. All right. And that's your CPR.
Do it over the red plus.
Yes, exactly. Yeah. If you right on that red plus. Yeah. And then on top of that, stress also ultrasounding the heart, then you're like sound jet, slimy, or like sweating all over. So sometimes you can just throw washcloth on top of their chest. It's just so we don't slide everywhere. Other questions? Yeah. Stupid question. There are no stupid questions. We're learning.
You know how you say like you're there's 3 other people. How do you guys like do
we have a stool?
Oh,
So we usually drop the bed as low as possible. Usually the person pushing them into a setting bed. Hardboard. We the step stool is probably about 9 inches. And then step down above the step stool. Yeah.
you have to break the ribs.
So a lot of times you'll end up usually happens in the first couple of like compressions that you do. And then after that, things are just like a little bit more lumpy. It sounds really disgusting. Patients that are older have like very thin and brittle bones, you can break ribs on them.
What does recovery look like?
Oh my gosh, terrible. So the data actually shows it. I mean, use trauma data, but if you're having and if you have like 4 or more fractures or more mortality is like incredibly high. And that might be really high. I don't quote exactly on this, but I want to say it's somewhere in like 60%. And each rib fracture past that, your mortality gets closer and closer to 100. So they're using trauma data. It's going to be similar to something like CPR because you every time you breathe, because the muscles are moving and you're causing things to shift. When they get shifted. So you don't breathe as well. The air balloons in your lungs. And then they don't clear out as well. So you have fluid in there. That fluid sits infected, and then you get pneumonia. Now you have an infection. You're getting even more sick. And so they tend to not do very well. So I'm going to guess that they multiple rib fracture are probably like not awesome. You guys about all of this, what percentage of people that have an arrest that we do see people these medications to actually come back? Yeah, so it's going to depend on the time. Do we think we're looking at 50% that survive? Do we think we're looking at 40% that survive? 30%, 20%, 10, 9, 8, 7, 6, 5. 5%. Okay. So that's survive. That doesn't necessarily mean that they're going to get up and walk out of the hospital. Okay. That they survive. They may go spend their entire life in a care facility with a breathing tube in. But a small percentage of them will be able to get up and walk out of the hospital. Yeah.
At what point do you decide to stop CPR and just do it for
So that's based on trauma criteria. We don't do that on medical arrests. And that is going to depend on the amount of time that they are down before they get to us, and it's going to depend on the chances of them having like an intrathoracic issue or something in the belly that we can cross half of the body and actually control. So realistically, if they're penetrating pulses in that's less than 10 minutes, we'll crack the chest on that patient. So we'll do a long incision along their second, third intercostal space from their sternum all the way to their posterior maxillary line. We'll cut open the intrathoracic rib muscles. We will put rib spreaders in, and we will